we're going to start by just talking a little bit about the patients who are likely to be using substances while in hospital. And so I'm going to start kind of presenting a bit of a profile of those folks. So first of all, my name is Andre Cahill. I'm an addiction social worker who works with the Addiction Medicine Consult team. So I work with people throughout the hospital who could benefit from some enhancement of their motivation to make change, or who are looking to make changes, and I help facilitate that through doing referrals to treatment centers, or just discussing with people some of the options that they might want to pursue when they leave hospital, and how to get referrals done outside of hospital. So all things about resources and connecting to recovery supports for them. So a lot of this stuff, obviously, as seasoned professionals, you'll all likely know about. And what we usually first talk about is the values and judgments and emotions that healthcare providers have towards people with significant addiction issues. So those are folks that you see who it's obvious, either when you're seeing them in ER, that they have serious withdrawal issues, or possibly psychotic issues connected with their substance use, or obviously high when they come into hospital. So we all come to patient care with our own personal values and judgments around things. And working with patients with addiction issues, we can all often feel frustrated by their continued use, despite the negative consequences attached with their substance use. And so in hospital, that's usually some kind of infection or psychosis. They've been picked up by the police, or some other medical illness connected with their substance use. So it's not surprising that many people with addiction issues actually avoid coming to the hospital, because they've had negative interactions with healthcare providers when they've come to hospital. So they've come to hospital and they say they're sick, or they have they're in pain, and people will question, are they really in pain, and kind of be very skeptical of the issues that they're presenting. So, or they can be, and this happens all over, they come to hospital and they're treated really poorly, and they end up kind of leaving in frustration that they feel they're obviously being kind of stereotyped, and they feel stigmatized by that. Also, when they're coming into hospital, they're sometimes in withdrawal or have been away from using their substances for an amount of time, and they can be very irritable, high emotions, high drama, which of course, as busy healthcare providers, especially in ER settings, that's difficult to work with, and we're already loaded down with a lot to deal with this person's their behavior issues. So those kind of things play into how we work with people in hospital. And it can also roll over into their stays on the unit, where they're, nurses and other healthcare providers might be having attitudes towards them, such as, I've seen this guy in hospital 6 times already this year. they're obviously not, kind of pulling up their bootstraps and getting on with their life, and why do I keep putting this energy into them, because they keep going out and using and coming back despite saying, oh, I'm going to change this time. Those kind of things can make it difficult working with patients. As can it can be difficult when we feel people are using substances while in hospital. Maybe they go down to the 4th floor and are kind of out in the garden for a while and come back, and seemingly their disposition has kind of changed, and they may present as high or acting differently. So when we look at substance use, of course, we're looking at a spectrum. And it's just not a spectrum in terms of some substances. It's a spectrum in terms of all substances. And I say that because sometimes we think about, oh yeah, some people are, use alcohol in a non-problematic way, but this person is using crystal meth, so it's obviously a serious issue. And that's not the case at all. People use cocaine, crystal meth, even things like heroin in what could be termed a non-problematic way. And when I say things like heroin, sometimes people will use heroin on the streets for pain relief because they have significant pain issues that either their prescription is run out, or for whatever reason they're needing to get pain relief, and that is the thing that's immediately available to them. But a lot of the people that we're going to be seeing at St. Paul's who have addiction issues tend to be, or the ones that stand out for us, are those with problematic and dependent issues. And certainly a lot of the folks that this policy is targeted towards is people who are so dependent on a substance that even when they're in hospital and our team is trying to keep them pharmacologically comfortable while in hospital, while their medical issues are being dealt with, even that doesn't kind of keep them comfortable. And those are the folks who are going to who likely use while in hospital. Those are the folks you see out on the 4th floor.
Good morning, ladies and gentlemen. If I may have your attention, please. We will be conducting a bell test in the Burrard building. There's no need to be alarmed. It is only a test. Thank you for your cooperation.
So those are the people who are likely to be smoking a joint, or maybe even smoking some crack or whatever else they do out there. So those are the folks that this policy is primarily geared towards. So we know that when a person gets to the dependent and the problematic stage, and particularly the dependent stage of substance use, you're looking at people who have moved beyond increasing their tolerance to a substance, that is using more and more of a substance to get the same effect that they got upon initial use of the substance. But they're also moving to the area of using just to feel normal. So that's where the substance takes over, and they kind of no longer have a choice around using substances. So that's the kind of people, if we're talking about smokers or people who use tobacco, we'd be talking about the person who wakes up at 2 and 4 in the morning to have a smoke because they can't do without it for a whole night. Or the person who has an alcohol use disorder who keeps a bottle of vodka by his bed even though he's been drinking all day. He knows he's going to wake up at 2 o'clock and he's going to be in rough shape and he'll need to drink, or else he'll have the DTs. And similarly, obviously with opiates, they have the same, obviously opiate addiction and tolerance is probably the fastest tolerance that develops, and a result of which is that in North America, opiate use disorder is the largest kind of increasing disorder among other substances. Often people are starting in hospital or get some opiates from their family doctor for whatever pain they've had or after an operation, and they continue using it, and then they find that it not only helps with their physical pain, but other pain issues that they have are also kind of helped through that emotional stuff, situational pain, and they use that. So things develop to a point where you're no longer using to feel good, you're using just not to go in, so you don't go into withdrawals, because withdrawals can be so painful. So that's an important thing to keep in mind, is that a lot of the folks that we're seeing, the kind of street involved people that we're seeing in the hospital that are up on the units right now, those folks, the party was over a long time ago. They're just using just to get by, and changes have happened in their brain that have made it that it's hard for them to stop using, because they're so their body and their brain and their behaviors are so geared towards using substances. All their relationships in their life involved other substance users. Maybe their partner is a substance user as well. Maybe their situation is that they've been using since they were 16 or 17 years old. They've never, substance use often impacts on a person's social skills and social maturity and development. And so when you start using substances in a kind of serious way early, it really makes your ability to mature, it basically shuts down that progression in maturity. So you'll see I'll see some guys who are like 52 years old and they kind of act like they're 16 or 17. It's because they started using substances quite early and their maturing stopped at that time. And so people have never had jobs or had such spotty employment that by the time they're, even 30s, 40s, and 50s, the idea of changing their substance use is like telling them to change their whole world. And if people have that motivation to change, and they're ready to change and willing to change, they can make those changes. But oftentimes, it's important to understand how all-encompassing an addiction can be, especially a long-term addiction. And we're seeing a lot of those folks through our team and the addiction medicine team. So we know that nurses are also seeing them. We also know that people are drawn to psychoactive substances as a form of self-medication to deal with stress and trauma. And so when we're looking at how that works, stress and trauma often results in symptoms such as depression, anxiety, and what better way to self-medicate for depression than using stimulants, or dealing with anxiety by using alcohol or benzodiazepines. So, or heroin for that matter, or other opiates for that matter. And a lot of the folks that I work with and see in the hospital here are people who have not just their own addiction that they're dealing with, they're also dealing with a family history of addiction and mental health issues. And also to the point where it's really intergenerational. Their parents were heavy substance users or had significant substance use problems. And so it's not just, and so when people grow up in homes where there's a lot of substance use, what happens is that, you know, if you look at the parents' role in the family as being kind of the up at the top, and they're the ones who are kind of calling the shots for their kids, when parents are using substances, they often kind of go into more of a role of being like children. And the children end up having to take on adult roles. The result of that is that there are all kinds of boundary issues that come up. And people grow up without a clear sense of boundaries, without a clear idea about how to take care of themselves emotionally, how to, any ideas about regulating emotion. So this is the type of folks that are kind of really substance dependent and the kind who are likely to continue using substances while they're in hospital. In terms of trauma, I'm sure you know that a big part of trauma is really understanding that understanding how common trauma is. And certainly within addiction, it's generally, research shows that 90-95% of people with addiction issues have had serious trauma in their past, whether it be physical, psychological, or emotional traumas. So that's important to keep in mind, and to keep in mind that trauma really impacts their development and leads to a lot of adaptations that they make that in order to cope and survive with the trauma. And some of the ways that they cope and survive with that trauma is through using substances. And so in terms of the principles and best practice around working with people with trauma, it's important to create safety and trustworthiness with them when we're working with those folks. And then it's also important to work collaboratively with people, and we're going to talk about some concrete examples of that in a bit. And it's really about focusing on strengths-based with those people. So obviously they've been shamed their whole life, so when we see them obviously using in hospital, it's not going to be useful to say to them, you shouldn't be using while you're here. Why are you doing that? What are you doing in hospital if you're just going to be using anyways? A more kind of appropriate response based on what we understand about trauma is developing positive communication techniques. And that can include things like, when you see somebody coming back onto the unit and they've been using say to them, once they get settled in their room or what have you, I notice you seem to be a bit different than when you left. Just wanted to let you know, it's important to let us know if you're using substances while you're in hospital because of how the medications we're giving you might impact on or interact with what you're using. And so if you let us know that, then we can make sure that you're safe and that you continue to heal as well as possible while you're in hospital. I think I'll stop there. Are there any questions, comments that you have? All right. And I guess the question of how we can help people, I just mentioned that that communication intervention right there, but what's also helpful is matching interventions to a person's stage of change. And one thing that at least Jane and myself are working on is a CCRS module that begins to look at practically what that looks like. For instance, when someone's not really thinking about making changes, when they're in the pre-contemplative stage, what really works for them is just being supportive to them, and when the opportunity presents itself, connecting some dots with them. And by that I mean, sometimes people, in the pre-contemplation stage, somebody's not wanting to think of their problem. They're not, or they're underestimating the result of or the negative effects of their addiction issues. And so connecting the dots can be really, really useful with them. And that's just, so sometimes, like a guy came into a hospital a few months back, 52-year-old guy, used alcohol a fair amount since he was in his late teens, sometimes a Mickey or two a day, but hadn't had any negative consequences. He comes into hospital after, vomiting blood and comes in to emerge. He ends up on the unit. He's jaundiced and he has, his belly's all full of, he has ascites. Is that what it's called, ascites? And he's sitting there and he doesn't know what's going on. He doesn't know why he's in hospital. He hasn't made the connection that it's the alcohol. Why would he? He's been drinking all this time. There hasn't been a problem. And then he also didn't know when I was talking with him further, he didn't know that when he was told about having liver problems, he thought the liver regenerated. He thought the liver was one of the organs that regenerated. So he felt pretty comfortable that if he took it easy on the booze, he would be all right, and his liver give his chance of his liver to heal up. And so that's an example of someone who hasn't connected the dots. And we often we assume people, well, obviously you have an injection or you have an infection right where you've been injecting drugs. So obviously that's why that's happening. But I've talked with plenty of patients that haven't really made that connection. They'll say, oh, I fell off my bike a couple weeks ago, or I banged into a chair, or I fell when I got out of bed. So interventions like that are really important. And so for somebody who's pre-contemplative, talking with them about, you should really go to treatment. Do you want to hear more about treatment options? That's not the appropriate intervention for where they're at. So we're going to be providing more of that information both in the module that we're doing and in our work with nurses on the units. So I think at this point I'll turn it over to Jane.
All right. So I think it's kind of good for you guys to understand where this all came from, because of course it was a huge change in policy when this new policy came out in July, and I kind of anticipated that it was going to sort of set the cat among the pigeons, if it's probably a good way of describing it. People kind of went ape shit. Anyway, so I think you have to understand the background and why this happened, okay? So what you need to know is that we actually did a research project. I did a research project in collaboration with Annette Brown, who's a nurse researcher at UBC, and Bernie Pauly, who's a nurse researcher at University of Victoria. We got a Michael Smith grant to do a project. And what we were particularly interested in is the experiences of patients who are admitted to acute care hospital who have an illicit drug use issue and are marginalized. Because as Andre mentioned, lots of people use illicit drugs and are perfectly functional. That we're talking about the visible addicts, the ones we see here that really cause a lot of challenges for us. And so what do we know? We know that hospitals are risk environments for patients. The social and structural conditions of conventional healthcare create a situation where patients are reluctant to seek care and often leave against medical advice, and we know this. A large proportion of people who use drugs do so while in hospital. They don't stop just because they're here. And when harm reduction is integrated with medical care, substance users are more likely to access the healthcare they need when they need it. So the other thing we know, of course, is that nurses have a professional ethical commitment to provide nursing care on the basis of need.
Ladies and gentlemen, as per the bell testing, we will be ringing the bells on levels 4, 3, and 2 for the Burrard building. Again, it's just a test. There's nothing to be alarmed. And we will be ringing bells on levels 4, 3, and 2. Thank you.
Okay. And I should mention, actually, that there's a very good document that's available from the Canadian Nurses Association. They published a policy document on harm reduction about 5 years ago, well worth having a look at. So if you feel like going to the CNA website, you can find it. It's not hard to find, okay? Obviously, nurses need to shift their attitude from fixing people to people fix. I think, we often come at our patients with the attitude, you have a problem and we need to fix it, as opposed to just accepting the fact this person uses drugs and that's just the way they are, right? And so harm reduction, actually, and the other thing to understand about harm reduction is it's actually it's a continuum, right? From active drug use to abstinence. Abstinence is part of harm reduction. It's one of the goals along people's journey. And where people start out in harm reduction is really very much dependent on where they are in their lives at the present time. And Elise is going to talk about a lot more about this. But if abstinence isn't possible, it's not ethical to ignore the other available means of reducing suffering, right? And so harm reduction, these are not my slides. These are your slides, aren't they? No? It's about more than reducing harm from drugs. It's about taking action to address the broader social conditions that contribute to inequities. And we know that hospital-based harm reduction interventions improve hospital care retention, promote patient-centered care, and reduce adverse health outcomes. So what did we discover from this study? I thought I put these slides in here, but apparently I didn't. Well, it was really interesting, actually. So we did this big study, and it was an ethnographic study. So we did observations of nurse-patient interactions. We looked at the documents that were available at the time, which were pretty archaic, and we interviewed people. We interviewed 15 patients and 18 nurses, and we said, what makes you feel good when you come to hospital, and what makes you feel threatened, and what makes you feel bad? And the patients were really interesting, right? So they told us things like this. They said, when we come to hospital, we feel like we're under surveillance. We feel like we're being treated like criminals, like the nurses always have their eye on us, they're really suspicious of us, they think we're going to do something bad, always. They just make an assumption. If you're a drug user, you're going to commit a crime while you're here. If anything goes missing on the unit, the first place they go looking for it is that patient's room. And in fact, it was interesting, one of the interviews that went on with one of the patients, while our research assistant was in there doing the interview with the patient, the nurses came in to go scour his room looking for something that had gone stolen. They didn't find it, but that's what they did, okay? So patients have a very clear concern that they're under surveillance and they're under suspicion all the time. The other big concern for patients is that they're very reluctant to ask for analgesics because they figure if they ask for analgesics, people are going to assume they're drug seeking, because that's often the response they get. So what ends up happening is even if they are in pain, they won't ask for anything because they're just so worried about the kind of reaction they're going to get. Okay, so what they told us made them feel good was when nurses took the time to just do small things, even if it was just giving them a glass of juice or giving them a warm blanket. The idea that you would pay attention to those small things meant that you thought that patient mattered, okay? Taking time to talk to them, to find out about their lives, figure out where they came from and the challenges they were dealing with, all that stuff they felt was really made them feel better and safer about being in the hospital, okay? What we found out from the nurses, the most particular and most important thing in terms of what we're talking about today that we found out from the nurses was that they often knew that patients were using while in hospital, but their tendency was to just turn a blind eye to it, to just pretend it wasn't happening, okay? Because the hospital's policy at the time was very absent-based. It was very much about no drugs everywhere, anywhere, at any time. And so nurses didn't really know how to cope with the situation. Even if the nurse actually did have a good idea of what harm reduction was about, they didn't feel that they could provide any harm reduction services given the hospital policy at the time, okay? And that was concerning to us because, of course, when you have patients that are using, that's an opportunity to have a conversation, right? When you have a patient that's actively using, that's an opportunity for you to talk to that patient and say, hey, you just come back from the roof garden and you seem to be a little bit high, and I'm just sort of wondering what you've been up to. Can you tell me what you've been using? Oh, what are you doing to use that substance? Are you making sure you get a clean needle? Are you making sure you're swabbing off your skin with alcohol before you inject? Because if you swab your skin off with alcohol before you inject, you won't get cellulitis, or you're much less likely to get a cellulitis. So those are the kinds of conversations that as nurses we need to be having, and what are you doing to make sure you're safe? Because I'm really worried about you overdosing and nobody finding you. And those are the kinds of conversations as nurses we need to be having with our patients. It's super important. Because it really helps to build that therapeutic relationship. If you can have that kind of conversation with a patient and not make them feel bad about their drug use, right? So that's the big thing that came out of this research project. And of course, when we took it to Scott Harrison and Julie Kill, they looked at it and said, well, clearly we need to make a change here. And that's where this new policy came from. So that's kind of cool that we did this research and we managed to make new policy. It goes to show you sometimes you can do things with research. So anyways. So this was a study. And this was the other things that patients told. Didn't want to be written off, wanted to be trusted. And you know, if you want trust from your patients, you have to give them trust. Like it's a two-way street, right? Taking time, giving them space, not like being on top of them all the time. And I told you all that. And so the thing we understood was that if you use cultural safety to frame your care, that can make a huge difference, okay, to the way that you deal with your patients. You need to foster their engagement and participation. They're the experts in their lives. They're the experts on their sense of health and well-being. You need to talk to them about what makes them feel good, what makes them feel bad, what we can do to make things better for them. You need to actually integrate them into your plan of care, like we do with any other patient, right? And we have to understand that their priorities and their experiences are very influenced by history and the policies that criminalize drug use. They make all kinds of crazy decisions from our perspective that don't make a lot of sense. But you have to understand the context of where those decisions are coming from, okay? Because that'll really help you understand your patients and understand where they're coming from. And you have to understand how, and Andre mentioned this, past histories of trauma, violence, layers of disadvantage and stigma can affect their ability to engage with providers and care plans. And this is super important. There's this thing they do called the Adverse Childhood Experience Survey. And I read a quote one day that said, the ACE scores for people who use drugs are like off the charts. They are significantly higher than any other population that does this survey. Like they're completely off the charts. That's how bad it is, okay? You need to emphasize trust, as I already mentioned, and create a culture of respect and safety. So as a unit, and as an individual nurse, but as a unit collectively, you need to make these people feel that they're safe with you, that they're not unsafe, but that they're safe, okay? It's hugely important. We also know you need to set boundaries. It's super important with this population. And what I've actually noticed about this population in general actually is they don't mind having boundaries set for the most part, because they have a lot of anxieties and uncertainties about being in hospital, and when you set clear boundaries, it actually makes them feel more secure. So as long as the boundaries are reasonable, it actually is quite helpful for the patient. Make sure that street-involved people learn not to trust, so they can seem difficult to deal with. You need to understand that that's a typical presentation for them. You need to be clear about your expectations, but at the same time find a way to make it work for the patient. If they don't see a benefit, they won't be cooperative. So it's very much a two-way street in terms of making sure things work, right? So you have to make it a win-win scenario. So like you got this patient who sometimes disappears, and misses his antibiotics. So write the antibiotic schedule on their whiteboard. Say, okay, I don't really care what you do in between, but at these times you need to be here, right? You're setting a reasonable boundary. It's reasonable enough for them to adhere to. And you're also saying, it's okay if you wander off, as long as you're here at these times, right? Okay, Elise.
I think one of the things about this practice change is there's going to be so many practice changes, and like Jane said, like being able to have these conversations with the patients. But in order to do that, I think it's really important that we like understand just like the basics of what harm reduction is. So Jane mentioned a lot of this. Andre kind of talked about it as well, but sort of just to go back over what are the key principles of harm reduction, and then so we understand how that's informing the practice and the decisions that we're making. So just a bit about harm reduction. So it's a public health approach. It uses evidence-based programs. So this is something that's been in the community for a long time, and there's a lot of research and evidence that shows that harm reduction actually is the best practice, and that abstinence-based policies don't work, basically. People often think about substance use when we talk about harm reduction, but it's actually, we've been practicing harm reduction forever, right? If you think about seatbelts or helmets or things like that, like it's just basic kind of principles to be able to reduce the harm of any behavior. And then within the context of substance use and sexual activity, things like insight, safe injection supplies, condoms, things like that. So just some basic kind of things that we do. So these are some thoughts that have come up a lot about harm reduction. And basically, I'm not going to go through them all, but they're all myths. So research has been done to disprove every one of these. But it's just some things that you often hear. So when people are thinking about, reasons to disagree with harm reduction, these are usually some of them, but they have all been disproven. I'm not going to talk about the research for all of them, but just to know. So to talk about the key principles. So the first one is pragmatism. So like Jane said, a lot of society thinks that drug use is just a choice and that people can just stop. Why don't they just stop, right? And so I think just understanding that that's not really the case. And just because some people can maintain abstinence doesn't mean that everybody can. So what works for someone to maintain abstinence doesn't mean that it's going to work for everybody else. And then ultimately that fixing is not the option. So we can't fix people who use substances. And what happens is nurses and other healthcare workers often get, they get frustrated, right? And then that causes burnout, and it just makes it all worse if we're constantly sort of accusing or being judgmental to people who are using substances. And then when nurses feel burnout, then they can't develop therapeutic relationships and sort of so on. So just being pragmatic and understanding that people are going to use substances. So what can we do to help them? So the other thing we want to do is focus on harms. So identifying sort of what is happening for this person in this moment, and what can we do to make this behavior less harmful for them. So any interruption in harm should be regarded successful. So this is where Jane was talking about that continuum of harm. So if you think about abstinence, I wish I could draw it for you, but if you think of abstinence on one end, and say somebody is using IV cocaine with not clean needles in their house alone, so that's kind of where they are on the other end. If we can even get them to a state where they're using at insight, then that's a success. Like, we shouldn't just think of making abstinence a success. We think of any sort of shift down that continuum to be a success on our end. And then so it's often achieved in increments. So subtle changes over time can help us get to a place where they're a little bit more safe with their use. Prioritization of goals. So that's exactly what Jane talked about with that CNA document. So that nurses have the responsibility to care for all individuals based on their individualized and identified needs. So avoiding focusing on abstinence, and then also understanding that individuals will identify their needs differently. So this can be, just basic examples like, if someone is living in a SRO where there's a lot of drug use, and as soon as they go home, all of their neighbors are going to be using, then the thought for them of decreasing their drug use or stopping is just not it's not sort of on their mind. Or even worse, if they don't have a home to go to, and then we're trying to get there to decrease their drug use. Like, it's just not one of their priorities. So kind of identifying their needs in that moment, and then trying to work with that, and then hopefully leading later on to be able to address their drug use. Humanism. So as Jane and I think Andre also mentioned, a lot of people who use substances either avoid healthcare altogether, or they often leave AMA after being here for just a short time. A lot of them have had really, really negative experiences, either in the emergency room or on the health floors or on the hospital floors, or even just like at a doctor's office or any sort of healthcare environment. And so then it's often because they feel shamed, so they don't feel worthy. They feel like they're being accused of doing things. So I think here it's just really important to, understand the inherent worth of all individuals, understanding that everybody comes from a place or, trauma-informed care, something, what has happened for this person in their lives that sort of got them here, and understanding that, they didn't probably make this choice to get here. And then it's when we can create these relationships and, develop a therapeutic relationship, then the patient will be more empowered to change. So creating those kind of bonds allows them to feel more empowered to change any sort of harmful activities. And then autonomy. So ultimately, the patients are responsible for their own choices. Like, we're never going to we can't change them. It has to come from a place where they want to make the change. So this is really about providing information so that they can make informed choices. So I think Andre said, so you can't just say, like, we think you should go to treatment, here's all the information about treatment, but sort of bringing it out of them based on their stage of change. Are they asking about clean needles, and then we can provide that information? Or are they sort of talking about treatment, and then we can provide that information? But understanding also that a lot of these individuals don't have the ability to make decisions. So they've never really had to make these decisions possibly in their lives if they started using when they were young. So just providing with like the empowerment, therapeutic relationship, information to be able to sort of make decisions. And that's it. Do you have any questions just on harm reduction? No? Okay. Jane? Izzy?
Or so you're gonna wait till the end to talk about
Question about abstinence, total abstinence. Like
Yeah.
Programs like AA historically have been very successful.
Yeah.
They are successful.
Right. So abstinence is like that's what I meant understanding that works for a lot of people, but it won't work for everyone. So we can't assume that everyone is going to be able to maintain abstinence, even though we've seen such success with other people, right? It just, exactly.
I mean, we talk about harm reduction, and I'm a total proponent of harm reduction. I think it's super important that we provide people with the means of using safely. It's hugely important. But I mean, at the end of the day, I want people to be abstinent, right? That is my goal. Abstinence is my goal. It's always my goal. Always has been my goal. Nothing's changed, right? But some people take a long time to get there, right? So, yeah.
So I'm just wondering if trauma is so prevalent in this population. You mentioned the term like trauma-informed care.
Uh-huh.
Just say a little bit more about that.
Okay, so trauma-informed care is basically a concept, right, that is about, and it's very similar to cultural safety, in truth, actually. There's not a lot of difference between cultural safety and trauma-informed care. It's the most important principle of trauma-informed care is realizing how pervasive it is. I don't think we really appreciate with how many of our patients are actually have had a traumatic experience. It just doesn't seem to be forefronted. And that's true of people with HIV, it's true of people who use drugs, it's true of people with mental health issues, definitively. I mean, we know this. There's tons and tons and tons and tons of research that shows that experiences of trauma are significant. But even just your average general patient potentially has been traumatized. I think we have to understand that this is actually a really important principle to keep in mind when we're engaging with our patients, and to try very carefully and subtly to sort of get a sense of what that patient's life experiences have been, so you can figure out if indeed they have had trauma experiences. And if they've had trauma experiences, it's very much like cultural safety. It's about building trust. It's about trying to negate and minimize those power imbalances, because that's a huge piece in this. They don't trust because they feel powerless. Okay, so you need to build the trust. You need to minimize power imbalances. You have to understand the context of their lives and the kind of contextual issues that are impacting on the decisions they make and why they make them. Okay, all that stuff. So it's very similar to cultural safety. Does that make sense? Yeah. Okay. Anything else? Okay. So what's our philosophy of care? So we, as you guys know, we have 2 new philosophies, and it's quick and dirty. I'm sure you guys have all looked at them at this point. You probably understand the philosophy of care has changed a little bit in that it no longer says that abstinence is the only goal. It now says we understand and appreciate that some patients will continue to actively use while they're in hospital. We know this. They always have. Like, it didn't matter that our old philosophy of care said abstinence was the only acceptable outcome. Didn't matter that it said that. Didn't change anything. They still were using. So, like, now we're just accepting the fact and putting that in the philosophy. Okay, we understand that this is actually potential. Although abstinence and the philosophy of care also makes it very clear that we're going to support people to be abstinent while they're here. Because really, that's what we want. That's ultimately our goal. It always has been and it always will be. That's not going to change. The substance use policy, patients and residents for people who use substances at PHC, the alcohol and substance use policy, now actually clearly says that if you have a patient that's actively using, the first and most important thing, of course, is to notify the addictions medical medicine consult team. They need to know the patient's actively using, because they need to tweak their analgesics, they need to tweak their methadone, and hopefully get them to the point where they don't need to use while they're here. If we can treat their pain and their withdrawal to a good enough extent, hopefully we can actually stop them from using while they're here. So obviously notifying addictions team is a super important piece of this. But if they're using, you need to have that conversation with the patient. What are you doing? Where are you doing it? How are you doing it? And asking them, do you need some clean needles? Give them the clean needles. Do you understand why it's important to use an alcohol swab? A lot of these people don't get the alcohol swab. They don't, I mean, when you go to the needle exchanges, they will give you alcohol swabs along with the needles. A lot of these guys don't take the alcohol swabs. They don't understand or appreciate why it's important. But there's quite a lot of research out there that's very clear that if you swab off your skin with an alcohol swab, you're much less likely to develop a cellulitis or an endocarditis. So our patients need to know why it's important for them to use an alcohol swab. Why it's important to take the extra 15 seconds to swab off their skin before they stick that needle in their arm, okay? So we need to have these conversations with their patients so they understand why this is all important, okay? And that's why we've changed the substance use policy, because our patients are using, we know they're using, and we need them to be safe, okay? Make sense? Okay. So it's about talking to your patients about their drug use. And I find in general, like, I mean, I've been dealing with these patients for 30 years. And I mean, I worked in emergency for 20 years. And I mean, we saw a lot of patients down there who are substance users. And I always asked them about what they were doing. And what I always said to them is, I need to know this because I want to look after you properly. And I can't look after you properly if I don't know what you're up to. And I find in general, if you explain it to them that way, they'll usually tell you. They're not that big on hiding it. They just need to know why you need to know, right? And if they think you need to know because you're going to tell on them or get security involved or something like that, yeah, they're not going to tell you. But if you explain it in that, I want to look after you and I want to do a good job of looking after you, and in order for me to do that, I need to know what you're up to, they'll tell you. You almost always will, okay? Like I said already, review harm reduction strategies for patients, offer them clean supplies. And the other thing I think is a really big concern is, I mean, we know historically patients have hide to use drugs because they don't want us to catch them, so they hide in the bathrooms, they hide in the showers, and that's a huge concern, of course, because if they OD, you might not find them, right? And that's problematic. Now, of course, the substance use policy is very clear that they have to use off-site, and there's a reason for that. It turned out that Insight is allowed to watch patients use on their premises because they have an exemption from Health Canada. We don't have an exemption. We're working on getting an exemption, I might tell you. But because we don't have an exemption, nurses can't actually supervise patients who are using. You can't supervise their injection. Ultimately, what I would like to see happen is first be able to say to our patients, if you're going to use, we want you to do it in your bed with your curtains drawn so you're not upsetting the patients around you, so that I can keep an eye on you and make sure nothing bad happens. That's ultimately what I would like to see, but at the moment we can't do that because we don't have an exemption. So at the moment, what we need to tell our patients is, if you're using, you have to go off-site. But if you are going to do that, please make sure you're somewhere where someone can find you if something happens, okay? Because that's the other piece, right? Obviously document it. So if you know your patient's actively using, please document it in the ID notes, because the addiction team needs to know what's going on, right? Otherwise they can't do what they need to do in terms of supporting the patient. And obviously our ultimate goal is always abstinence. So like Andre already mentioned, consider the stages of change. So if your patient is contemplative, like they might be pre-contemplative, they might be saying, you know, there's nothing wrong with what I'm doing. It's a solution to all my problems and I'm just going to continue doing it. However, they might be contemplative. They might be saying, God, this is the third time I've been admitted to hospital in the last 6 months, and I think it's because of my drug use, and maybe there's something maybe I need to change. Those are patients you're sort of going to engage into conversation and say, okay, what's good about your drug use? What's bad about your drug use? What are the pros? What are the cons? Where do you see yourself being a year from now, right? Do you have any plans for a year from now? Do you think you'll be able to get there if you're still using these drugs, right? So having that conversation to sort of hopefully get them to the point where they're actually ready to start making some decisions, okay? Okay. So, you walk into the room and observe Cheryl is injecting an unknown substance. What is the first thing you're going to say to her? Put your microphone on when you answer these so that the camera picks you up. What are you going to say? What are you doing? Okay, turn your microphone on. Tell me what you're going to say.
I'm not an expert at this, but I'd say something like, I notice you're using some substance right now. Are you comfortable sharing with me what you're using? And my concern is that it may interact with some of the medications that you're on in hospital.
Perfect. So, having said that, what's the important information you need to know, and how are you going to ask for it? Yep.
What the substance is?
Yep. You want to know what they're using. What are you doing exactly? What's the drug? Yeah. Where'd you get it? Did someone bring it in for you? Which we kind of like to know that, but yeah. And what are some important things you need to talk to Cheryl about?
Well, would one of the things be that you've walked into the room and they're openly using? That
Yeah.
would be a problem.
That
So
would be
you
a problem.
Talk about
Yeah.
shutting the curtains and.
Yeah, it's a problem
After.
because, of course, it's a trigger, right? And, you know, we have other patients that are struggling to stop using while they're here, and they have a patient in the room that's openly using. It's a huge trigger for them, right? So, yeah, you'd have a problem with that. If you walk into the room and she's openly using, it's like, Cheryl, you can't do this. And, in fact, you're not even supposed to do it in the hospital. But, you know, that's another story altogether. Yeah, so that's definitely something you want to discuss with her. What else would you want to talk to her about? What would you want to know? Yeah, where did she get her equipment? Where did you get the needle from that you're using right now, Cheryl? Have you used it before? Is it clean? Is it sterile? Yeah. Yeah, good. All right. So Rick has left the unit for the past 2 hours, and when he comes back, it is clear he has been using. So what do you want to talk to Rick about? What are you going to say to Rick when he comes back after being off the unit for 2 hours?
Again, what?
Turn on your microphone.
I have such a loud voice already. What he, or having that conversation that it looks like you've come back, you're a little bit different than when you left. Did you use, and what did you use?
Yeah.
Then explain why you're asking.
Yeah, perfect. And so, again, what are you going to talk to Rick about? Like, he's disappeared off the unit, and you haven't had, unlike Cheryl, you haven't even had the ability to know exactly what he's been doing while he's out there. So what do you want to know from Rick about what he's been up to, or what he's been doing? What are you going to ask him? Go for it, Julia.
I think sort of the same thing is,
Yeah.
first of all, how did you use clean equipment, and perhaps even talk about when they're able to, if they're,
Yeah.
at that
Yeah.
comprehensive
It
level.
might be too high when they first
Yeah.
come back, yeah.
And they're not on the, they're not
Yeah.
coming down, but
Yeah.
just saying that it's okay to tell us when you're going, just where you're going, so that we know where you're going and
Yeah,
that you're going to be
and we know
safe.
where to look for you if you
Yeah.
don't come back. Yeah, and I think that's quite important. So yeah, the hospital's saying they have to use off-site, but it actually is kind of nice to know, where off-site are you going to go to use these drugs? Can you tell us before you leave so that we know if you don't come back, where to go and find you?
Can I
Yeah,
just say something?
yeah, sure.
I think, and I don't know if we already kind of covered it. Also, one thing is when we're asking them, like, oh, what have you been using? How have you been using? Whatever, is like, are you in pain? Are you in withdrawal? Is that why you're using? Because if that's why you're using, then I'll talk to the consult team or look, you have a PRN methadone. Maybe I'll give you that. Or if he's been off the unit, like, did you go off because you're withdrawal and you needed to find something? And if so, next time you feel like you're gonna go, let me know and I'll see if you have a medication I can give you, or I can call the consult team and get more medication ordered, because clearly you're using for a reason, right? And like maybe if it's like crystal meth or something, they just want to get higher, I don't know. But if it comes to actually like using heroin or something, then they're likely just not, they're in
Yeah.
pain and it's not being controlled, and that's what the consult team is, that's their goal, right? Is to make sure everybody's comfortable while in hospital, so.
Yeah, that's a good point.
I think it's also knowing when your teachable moments are,
Yeah,
because when they're at that point where they're gone, they're not listening to you anymore.
No,
And
no.
they want just that pain medication.
Yeah.
So
yeah, yeah. Okay. So Mila is a difficult patient. She frequently disappears off the unit, misses her antibiotics. Sometimes she refuses to order tests. Today she refused her CT scan. What can you do to get Marla to be more adherent with her care? What kind of conversation are you going to have with her to try and figure out what's going on?
I think it would be pretty much the same.
Thing, that find out if she's having issues and why she's using and.
Yeah. But also, do you think that you want to find out what her history, her background's like? Yeah? Because, this is probably, a lot of this is about trust or lack of trust, right? She just feels very uncomfortable, unsafe being in hospital. Why is that? What's gone on in her life that she's so uncomfortable, unsafe being in hospital? Has she been subjected to significant abuse? Can we do things about that? Of course we can. We can refer to psychiatry. We can refer to addictions counseling. I mean, there's lots we can do to sort of support her to feel safer while she's in hospital. And it's also about you, of course, endeavoring to build a more trusting relationship, which can take some time, right, with these patients, because trust is not a very good street survival skill. Trusting people on the street's a very bad idea. So, that they've learned the hard way not to trust people. So it can take a while to build that trusting relationship, but it's certainly doable. It's just all in the matter of how you go about things. So, so what sort of issues do you need to explore with her? What kinds of things do you need to find out about Marla?
I would probably acknowledge the fact that she keeps kind of going away and saying I'm noticing that you're not feeling very comfortable in this setting, and what we're maybe asking you to do. So saying what can we do? What's going to make you feel more comfortable? What can I do to help you so that we can
I think that's an excellent way to
get
do
to that
it, right?
goal?
That's an excellent plan. Just say to her, you seem to be very unsafe here. What can I do to make you feel safer so you don't feel like you have to leave all the time? That's an excellent way to do it, because you're basically getting it from Marla. And so you're building that collaborative relationship, which is a really important piece, right? So, yeah.
Well, and it shows that we're putting her first.
Yeah.
Instead, or her goals first versus.
Yeah.
Even though we want to help her with the antibiotics and the test to really ultimately find out what the issue is, but we're really showing, okay, you're part of this.
Yeah, exactly.
Yeah, and I think just like with the ordered tests and stuff, sometimes when people refuse tests, it's just because they don't know what it's for. So, if you're woken up at 5 a.m. or whatever time for blood work and you're like, no, get out of here, maybe you don't know that it's for something really important, right? Or also with the antibiotics, if she's frequently missing antibiotics, often we don't tell them, you're gonna now get antibiotics every 4 hours for the rest of your hospital stay. So she might not know that it's coming at 12 and whatever times they come.
Yeah, so that's why I say, like, it's a good trick to write the times on the whiteboard and say, these are the times I need you here, right? In between, go ahead, wander around, I don't care, right? But at this time, I need you on the unit. And sometimes that's all it takes to make the difference. Because we make assumptions about people, right? We assume they understand. A, it's important for them to be there, and B, they know the times. They might not know the times. I mean, if we don't tell them, they won't know, right? We wander in and out whenever the hell we feel like it. They don't really have a good sense of time necessarily, right? So yeah, I think that's super important. Yeah.
I think it's also important to know that you can actually change times,
Yeah.
and especially for
Yeah.
students.
There's no reason why you can't.
Yeah, it's not written in stone. I mean, for our CF patients, because they've been in and out of hospital, just like addiction patients, and they might want to sleep in a little bit. There's nothing written in stone that we have to do things at the times that are
Yeah.
printed on
As
paper.
long as it's Q4H, it doesn't matter what Q4 it is, right? It can
Even
be
blood
10,
tests.
it can be 10, 14, and 18, or it can be 12, 16, and 20, right? It doesn't actually make any difference. Yeah, you're right. Yeah, it's a good plan. Good thought. Okay. John tells you he's sick of his life and wants to get off the dope. So what can you do to assess to determine if he's ready for treatment? What are you gonna talk to John about and try and figure out?
I guess you'd be assessing his readiness for
Yeah.
change. His
Yeah,
levels of
I'd be looking at his stage of change. Like, where is he at? Is he contemplative? Is he making plans? Does he have like a particular idea in mind of where he wants to go and how he wants to do it? Like, where is he at? Because that's going to change how you approach him, right? And what you talk to him about. If he's pre-contemplative, even if he says he wants to get off the dope, I mean, I've heard people say this like 1,000 times. When I worked in emergency, people were always telling me this, right? But when you actually talk to them, you realize that they were actually pretty pre-contemplative. So there was really no point going there. Like Andre said, there's no point talking about treatment with people who are pre-contemplative. You're just wasting your breath. They're not there yet, okay? So yeah, you want to see where he's at in terms of his stages of change, because that's going to tell you if he's ready, okay? And what can you say to support him in his decision making? What would you say to John, just so he knows that you're behind him and that you've got his back?
I would just say you're there to support him. You're there that you can give him options or refer him to the right people that he is.
Yeah.
Ready.
Yeah, so I'm going to repeat this because Catherine didn't turn her mic on. So you're going to let him know that you're there to support him and that you'll offer him the choices. And I think that's a really important piece of it, is offering people choices. There's all kinds of ways of going through treatment, right? There's day talks, there's on-site, there's residential. There's like a multitude of different ways of doing this, and people need to pick the one that's going to work for them, right? For some people, residential treatment's great, particularly for a lot of our population, because they often don't live in very nice places, so they're quite happy to go to residential treatment and get 3 square meals a day and a warm bed.
Bell testing, we will be testing these stairs in the Burrard building. It's just a test.
Yeah.
Thank you.
You know, so it's really important to offer them choices, right? Because what works for one person won't work for another person. So, okay. That's the end of my slides, but I think you have some stuff to.
I think you all got this, did you? So, Andre and one of the nurses from the IDC, Emma, do presentations at new grad orientation or new employee orientation every month, and so they just started sort of talking about some of this stuff, and the nurses obviously had questions, more practical, like, well, what would I do if blah blah blah. So we wrote down some of them, and we just put them in this document, and we don't need to go over them. And then also know that this is sort of like a working document, it's not done. So if you find errors, we know. So I don't know if you want to talk about any of these specifically, but it's just some points that will help us support the nurses when it comes to a little like more specific things that are happening on unit. So if you want to have a look briefly through that, and let me know if you want to talk about any of them. Oh, do you not have one?
No, I have.
Oh.
One of the questions I have is in regards to like alcohol use. Is it the same? And maybe it's 'cause I don't know. Like we don't, if they are getting prescribed alcohol, are we able to like watch them drink it at the bedside in the same way as substance, like as a like for them using?
Right. I actually don't. Jane would know more about
Well, the
the
managed
prescribed
alcohol
alcohol.
program, yeah, I mean, you just witness their ingestion
Okay.
just like you would with any other drug, like whether it's methadone or morphine or, aspirin.
Right,
Like,
because that's being prescribed
Yeah,
anyway
it's being
versus-
prescribed.
Okay.
So, it's not like they're street drugs, but you're not prescribed, it's actually being prescribed, so you witness your ingestion much like you would with your mouth. Yeah. I'm still trying to sort out a few things, which, not least of which is that pharmacy should be providing alcohol. Yeah.
It's coming from the community currently.
Yeah.
Any of the other ones you want to talk about? And if not, so also we left some time. So I don't know if you've all heard of the take-home naloxone program, but with the addiction consult team, we've also been offering take-home naloxone to patients that have been using opioids, and because the thought is often, like, even though people use while they're in hospital, a lot of people don't use, and so a lot of people do have kind of maintained abstinence. Even if they're on sort of maintenance therapy, like their methadone or whatever. And then when they leave hospital, they don't have a plan in place, so they go back to using, but they assume that they can use the amount they used before they came into hospital, and often that's, too much for them, so they'll overdose. So there's a huge potential for overdose once people leave the hospital, but then also in hospital. So we have the take-home naloxone kits, and it's not really, the process is still being developed, but right now, just the nurse who's working with the consult team at that time is giving them, but there's not always a nurse, so it's a little bit kind of touch and go. We'll figure out a process eventually. But I do have some of the kits here, and so I don't know if you guys want to look at them, and I can sort of talk to you about what I tell the patients when I do the training with them, and then that's sort of way you just kind of know what we do. I don't know if I have enough for everybody, but I have enough for everybody to kind of look at them. So I'm giving you actual kits, so if you can just make sure that all of this stuff goes back in, it would be really helpful.
Yeah, you can do it any time you like. Probably not.
Okay. So basically right now, a patient will be referred to me by the consult team. In theory, any patient who's ever used an opioid, whether they're an active user or they've used it like once in the past, is eligible. So in my opinion, the more that we get out of these into the community, the better. So I err on the side of, like, even if they're not have risky use right now, if they've never used opiates, or if they're on like methadone or anything, then I think that they should take one home, because usually, I've only ever heard of 2 people who said that they used it on themselves, because what they're doing is they're using it on other people, or other people are using it for them, right? So right now, and then I just go up to them at the bedside and I offer it to them, and in order to get the kit, they basically have to go through a little bit of a training, which I can kind of do for you right now, and I'll just tell you what I tell them, and then they can ask me any questions. So the first thing I ask them when I go up there is just to sort of break the ice, because I'm like, hi, let's talk about overdose, is I just ask them about experience with overdose. So have you ever had an overdose before? And most people have. And then I say, okay, well, what happened to you? Or if you saw one, like, what happened? What kind of things did you notice? And so that sort of leads us to start to talk about the signs of overdose. So, they'll be like, oh, I passed out and I wasn't breathing, and I'll say that's a good, someone who's overdosing might have no breath, or they might be taking very shallow, not maybe 2 per minute or something. Also, we talk about the fingernails could look blue, their lips could look blue, they could be cold to touch, and basically just sort of unresponsive. So we talk about that just so that they know what to look for when they look at someone who's overdosing. But I also talk about stimulant overdose and a little bit about alcohol. I just say, stimulant overdose would be the opposite. So someone's heart rate would be really fast. They might be a bit sweaty and agitated. And then with alcohol, sometimes they might be passed out and hard to wake up, just like opioids. And the reason I sort of talk about briefly all of them is because I mentioned that if you don't know what's going on with someone, you just give them the medication anyway. Because if they've just drinking too much alcohol and they're passed out and unresponsive, it just won't do anything to them, but it won't harm them. Or if somebody has taken stimulants and heroin or something, then this won't harm them. It'll just knock off the opioids, right? And so either way, it's if I took this right now, nothing would happen. So it's good to give it if you think it's a good idea. There's no liability or anything. If you think it's the best decision, then that's what you should do. So then what we do is go over the kit. So if you can see, if you look at this part, it's an acronym, it's Save Me. So we basically just go through the steps of what this is. So the S, so basically if you find someone and they're unresponsive, or you can't, you think they're having an overdose, you want to call 911. That's your first thing. And then you want to stimulate, that's the S. So I talk about shaking and shouting in their ear, trying to pinch them, or most effectively the sternal rub, so going right there. And I usually get the patient to do it to themselves because it kind of hurts regardless. And then just talk about that, or if they've ever had experience doing that. A lot of people will talk about, getting someone to walk around and that kind of stuff. And I say if they're walking, they're most likely not having an overdose, so you'd want to watch them. But it's actually if they're unresponsive that you really want to react. And then the second thing is the A, so that's the airway. So, tilting their chin up and checking in their mouth. So making sure that they're not choking on anything like vomit or anything. And then what they would do is they'd put on their gloves and sort of just scoop whatever was in their mouth out of their mouth to clear the airway. And then the next is ventilate. So yours will look a little bit different than mine, but there's a mask in them. This is a bit, you guys have a white package, I think. So it's basically one of these. So you put it on and they're supposed to give one kind of basic normal breath. And then, so this is where it gets kind of complicated. If they're with someone else, that person could continue to give one breath every 5 seconds. If they're by themselves, I tell them to just give one and then move on, right? Sitting there and doing one breath every 5 seconds for a minute before you move on to the naloxone isn't really going to get you anywhere. So you give one breath and then you evaluate. Has this woken them up? Are they starting to breathe on their own? Has you just moving them and doing that kind of stimulated them? And if not, you want to move on to the injection, so the muscular injection. So in each kit comes 2 syringes, and then if you open this up, there's 2 doses of naloxone inside. So this is where we start to talk about the medication. So I say, this is the medication, it's Narcan, it's in this bottle because it's sensitive to light, so don't take out the medication and leave it on your windowsill or something. You want to keep it in here if you can. A lot of people will ask if they can pre-draw the syringe. I don't technically know, but I say, yeah, if you're going to use and you're worried about overdose because you know that there's fentanyl or something possibly in it, then you can pre-draw it, and I just say then just keep it in the kit either way, just don't have it kind of out. And then the other thing we talk about is the expiry date. So I get them to just check the expiry date. The ones that I think you can all see right now are for 2017, so they have quite a long time. But also I do say, like, if you put this in your drawer and you forgot about it and then you found it in 2017 in a couple months, I would use it anyway because it's just a little bit less effective. So then I talk about how to draw it up. So I asked them if they've ever muscled drugs before, and a lot of people have. So that's kind of my lead way into be like, okay, well, you kind of know how to do this, right? So basically just, yours will have a plastic cap on it. So I just get them to, I ask them to look at it. I say, notice how there's a little bit of liquid up in there, and then you just kind of want to flick that down because the whole dose is the dose that you need. So that will equal to 1 ml. So I just ask them to kind of flick it down if they can, and then they'll just snap it off. And the reason the plastic's on the new ones is because it's protecting your finger. And then just like anything else, you draw it up and you get rid of the air, right? And so 99.99% of them are gonna know how to do that. And then if you look at the M, you'll see that in orange, the highlighted parts are where we want them to do the injection. So on the arm, the upper part of the bum, or the thigh. I always advise to do, some people ask me if it's supposed to go in the heart. I think they see that in Pulp Fiction. I'm like, no. I actually get that like quite a lot. I always recommend the thigh, and the reason for that is that these syringes are made so that they just go right through your pants. You don't need to like expose skin. So it can go right through pants, jeans, leggings, whatever. And I also think that because most people, or not most people, but quite a few people don't have much muscle on their arms, or they might be pretty bony. So in the thigh, you're just always going to get to some muscle. And I also just think it's easier because it's sort of right there. We do include alcohol swabs. So I say, if you are doing it in the arm and you notice that they're like filthy, then do the alcohol swab, but either just kind of ignore it and go right through the pants or the clothes or whatever. Because the thing is, you just want to be doing this quickly, right? So that's one dose. So then we talk about the evaluate, which is the last E. So you've pulled it up, you've given them the medication. I tell them that the medication takes about 1 to 2 minutes to kick in. So either someone will sort of wake up right away, and often that happens, and they wake up and they're angry because you've, put them into automatic withdrawal. But sometimes that doesn't happen. So within 1 to 2 minutes, if this person has not responded in any way, you give the second dose. And then hopefully that works, right? We also talk about giving them the first dose, having it working, and then if they've taken like a long-acting opioid, like methadone or Arcadian, like a longer acting, this only it works for about 30 to 90 minutes. I say an hour. So at that hour point, their overdose can actually come back and they can start to be unresponsive again. So they could give them the second dose. But we usually talk about like hopefully the ambulance would be there by then. And then just to tell the ambulance that they've given them Narcan. And one thing we really tell them is to stay with that person until the ambulance comes. And often people will get the Narcan and they'll want to use like immediately because they're feeling withdrawal. And so, explaining to them what you've done, I've given you Narcan and it's not a good idea if you use. Just doing their best to kind of keep that person safe and staying with them until the ambulance comes. I think that's all I tell them. Do you have any questions about that part?
Jennifer just had a really good observation actually on the header on the information sheet.
Yeah.
It says toward the heart.
Oh yeah, that's what the program's called, Towards the Heart.
Kind of at the bottom. And
Yeah.
or something.
That's
why they.
probably. This is kind of interesting. So this is all, we get this from BC CDC, like the hospital doesn't supply it, we get it from them. So they have the Toward the Heart program. This I talk about with people, but it's just kind of funny. It's like, okay, and then once you use the kit, fill this out. And it's like, I fax it in, like that's not gonna happen. So I talk about, the program is free. In order for us to keep it free, it's really important that we fill these out if we can. So I usually say, like, just leave it in your kit, and then once you've been trained once, you can just keep going and getting new kits. You don't need to keep receiving the training over and over again unless you want it. So I say, like, when you're going to get the new kit, so we talk about places they can go in the community, like where their doctor's office is, or if they can go to Insight or kind of wherever. I say just take this with you. And when you're asking for the new one, then the nurse or whoever can help you fill it out, unless you want to fill it out and fax it in. But that's totally fine as well. Yeah, and so once they kind of are trained, they can get as many kits as they want.
Do you have to have an order to get those?
So, no. For if you're, so, what is that thing called? There's a DST or it's a nurse. Nurses are allowed to, nurses can prescribe. So, what are those things called?
It's one of those things.
Oh, nurse initiated, whatever. Yeah, so nurses, so RNs can do this. So I have like a pre-printed one that I order. If I weren't to be on the consult team right now, doctors can also prescribe it. So for the program, there needs to be an educator, a prescriber, and a dispenser. So technically, right now, I am all three of those things, right? But it could be that the physician does the prescribing and a pharmacist does the dispensing and a nurse or whoever does the education. Like, as long as there's someone doing each of those points who can do those points, it doesn't really matter. But for us, or for the time being, it's the nurse who's doing it, but the doctors also obviously can prescribe it. There's like a decision support tool for it, basically just to guide whoever's doing it. So in order for a nurse to be able to do the training, they just need to have the education. So technically, anyone who's a nurse in this room has just had the education, so now you can do the training, like if you felt comfortable, right? So once you're educated, you're able to do the training. And I also mention that to patients as well. I'm like, now that you know this information, go and tell the people you're using with how to use this kit, right? Because then they'll know how to use it as well, and maybe it won't be as detailed, but
Ladies and gentlemen, as per the bell testing, we will be testing the bells and the stairs of the Burrard building. It is only a test. Thank you for your cooperation.
Yeah, that's kind of it. So, just while they're in hospital, so the process is I go up there, I talk to them, and then I give them a kit and I chart it everywhere, sort of. I put a note in the Cardex that says, like, this patient has been trained. The medication is to be kept with their belongings until they are discharged. So what I do is I take their labels and I label the bottle and I label the kit. And I give it to the patient, and they keep it with their belongings. So if they have a bag or they have all their stuff in a drawer or backpack, I get them to put it in there, because we were finding that people were getting the training and then leaving without it because it was being kept in, like, near the narcotic cupboard or something, and it was just like an afterthought. So now they keep it at their bedside, and I think, it's not, even though it's a medication, I don't really think it's unsafe, because they're likely not to use it, right? And it's a safe medication anyway. Except for on mental health. Obviously, we keep it with their belongings locked up, and then they can take it home when they go home.